Hey everyone, welcome back to another video. Today we're doing preeclampsia with eclampsia, okay? So preeclampsia is basically a new onset hypertension where you have the systolic is greater than 140 or the diastolic is greater than 90 and you have significant proteinuria at least greater than 300 milligrams. And this occurs after 20 weeks of gestation. You do have severe features with preeclampsia, and severe features are basically like low platelet counts, a serum creatinine that increases or doubles in time, and liver transaminases increasing or pulmonary edema. One of the big things that we watch out for with patients with preeclampsia is HELP syndrome, and basically it's elevated hemolysis with elevated liver functions and low platelets. Okay, so here it is. So hemolysis, elevated liver enzymes, and low platelets. And this is super important to know. And for patients who have preeclampsia, it does present in hospital settings. So if you are in rotations, you might see this in your patient one day. I definitely did. Now the cure for this is basically delivery. Okay, very important. And here is the risk factors. You can read them. Just pause them. Now, if you do have a patient with preeclampsia, the treatment would be you want to give a patient low-dose aspirin daily, okay? And then you also want to remember that the definitive treatment or the definitive cure for preeclampsia is delivery. Always, try to monitor your patient, and check their blood pressure. If you know that the patient's not gonna, if the patient's preeclampsia is getting worse, then keep close surveillance on the patients, and then also monitor the blood pressure. And if it gets worse, you're going to have to deliver the baby eventually. You're always going to try to prevent seizures in this patient postpartumly, or even if the patient has eclampsia. So and we'll talk about that in a second. So preventing seizures, you do a magnesium sulfate drip. Okay, if you do have a patient who is on magnesium sulfate, then they have a possibility of having magnesium toxicity. So watch out for that, especially in patients who have bad renal function tests, or renal functions. Then they might develop magnesium toxicity, and then the treatment for magnesium toxicity will be IV calcium gluconate. Now, if your patient does have preeclampsia with severe features, always control the blood pressure. Labetalol, hydralazines are your good friends here. Like I said before, magnesium drip is needed here, and then delivered by induction or C-section once at term. Not all your patients with preeclampsia, like I said, they don't always come to term, so you might have to deliver the baby just because the patient's vital signs and everything else is getting worse. So C-section or induction would be the best thing to do. Complications here, you can read that in a second. If you can't read this, it's serous retinal detachment. This is fetal or maternal death. Alright. Now, eclampsia. What's eclampsia? It's basically preeclampsia with seizures, and the treatment is delivery of the baby. Now, for seizure control and prophylaxis, same thing as preeclampsia. You give magnesium or magnesium sulfate. And if the patient does have a reoccurring seizure, you have to give IV diazepam. There you go. Okay, and like I said before, always monitor the magnesium levels. This does show up on NBMEs or UWorld a lot, so magnesium levels, monitor that. Magnesium toxicity, treat with IV calcium. Let's write that, IV calcium gluconate. And this complications are similar to preeclampsia. Hope that helps. I try to make it quick. I know this is a long one. Thank you very much.